We're taught to think about the don't miss diagnoses, the more serious things, as well as the ones that can masquerade, the mimics. You see someone that could have acute bronchitis. The more serious things I think about are like a heart failure exacerbation, a COPD exacerbation, an asthma exacerbation, a pulmonary embolism. These are the big scary things that I always think about.
Welcome to the Evidence-Based Urgentology podcast from EB Medicine, where urgent care meets evidence. I'm Joe Toscano, Senior Research Editor for Emergency Medicine Practice and a member of the Evidence-Based Urgent Care Editorial Board.
Hi there, and I'm Tracy Davidoff. I'm Editor-in-Chief of Evidence-Based Urgent Care, and we're practicing urgent care physicians with years of experience, probably too many years of experience, on the front lines. And for us, diagnosis is detective work, and the clues are in the history, the exam, and of course the evidence. That thrill of solving the patient's puzzle is really what keeps us coming back.
Each month, we unpack the latest issue of Evidence-Based Urgent Care, tackling common chief complaints from presentation through diagnosis to disposition. We highlight the best evidence, the key takeaways, and the clinical pearls.
And by the end of every episode, you'll have sharper skills, deeper knowledge, and more sound strategies that you can use on your very next shift. So let's dive in. The evidence starts now. And remember, you can always find more at www.ebmedicine.net. Today, we're going to talk about bronchitis. Welcome to the Urgentology podcast. This article has two authors. This was written by Robert Olympia from the Department of Emergency Medicine and Pediatrics from Penn State. And the person that's with us is Evan Nelson, who's a resident at the Department of Emergency Medicine at Penn State in Hershey, Pennsylvania. So welcome to you, Evan. We're happy to have you.
Thank you so much. I'm happy to be here.
Before we get started, we have a couple of promos to mention. The first one is a podcast exclusive promotion. If you go on the website and use the promo code podcast, that's PODCAST, you will receive 10% off your subscription plus Points and Pearls, the year in review 2024 and 2025. This is actually a $794 value that highlights key clinical insights from the past 2 years of evidence-based urgentology. The evidence-based medicine folks rolled back their pricing to reduce barriers and make trusted evidence-based education easier for clinicians to access. To see the new pricing, visit www.ebmedicine.net/subscribe.
All right, so we're going to talk about acute bronchitis today. Boy, really something we see a whole lot in urgent care and the emergency department as well. I feel it's really, I don't want to say nebulous, but somewhere along the line, we changed the framing of chest cold to bronchitis, which now people think is this horrible disease that requires all sorts of treatment. I really like how you framed it, Evan, as a diagnosis of exclusion, rather than just jumping right into that diagnosis of bronchitis. Really giving it some thought and making sure that you've excluded things that could either be masquerading as bronchitis or as other things. What are some of the things in your differential that you think clinicians should be concerned about before they hang the bronchitis hat on a patient?
We're taught to think about the don't miss diagnoses, the more serious things, as well as the ones that can masquerade, the mimics. You see someone that could have acute bronchitis. The more serious things I think about are like a heart failure exacerbation, COPD exacerbation, whether it's severe or not as severe, an asthma exacerbation, a pulmonary embolism. These are the big scary things that I always think about. But really the things that are even closer mimics and less serious are things like viral URIs, GERD, allergic rhinitis. These are things that really mimic acute bronchitis, and it's very hard to distinguish at some points. So that's the broader differential that I like to consider when I see somebody that has a cough.
That's always good advice. I always tell people, rule out the worst case scenario first. And once you've gotten through that, then you can think of all the things that are the lesser case scenarios. You know, in urgent care, those are generally the more common case scenarios rather than the worst, but that's always good advice.
Principle of the diagnosis of exclusion.
I forgot to mention pneumonia. That's another big one.
Definitely. Yeah, it's probably the big one, at least in urgent care, because everybody thinks if they're coughing up stuff, they probably have pneumonia. So yeah, definitely a good thing to think about.
So, Evan, we're hearing a lot about the advantages of respiratory virus testing. It's really big in urgent care. Helps speed along patient evaluation, possibly. It has been shown to decrease antibiotic use. But you and Dr. Olympia recommend very selective testing for patients. Does it just boil down to being comfortable making a diagnosis of a viral infection and only ordering a specific test if it's going to change management, such as if someone is in a risk group in a treatment window for specific antiviral therapy?
As far as the way I practice, that's how I like to think. Anytime I order a test or imaging, I ask myself, how, if at all, is this going to change my management? For somebody that I think has something viral, if they're within the window where they could get an antiviral like Paxlovid, Tamiflu, and I ask the patient if they do test positive for one of these viruses, whether it's COVID or the flu, would they like these medications? If all of those criteria are met, I consider a point of care test, the antigen testing that are rapid, cheap, and come back pretty quick. The PCR testing, where it's a broad RVP that tests for a lot of things, really doesn't provide a whole lot of value, especially in a fast track emergency department or urgent care setting, in my opinion. I reserve that more for patients that are being admitted to an ICU level of care. But for a patient that I think is probably with acute bronchitis, I think the point of care tests can be a good idea. The other things that you could test for, like mycoplasma, pertussis, things that need antibiotics, you do have the option of just treating them empirically as well. So I think getting a test for those wouldn't be a bad idea either.
You're right about will the results change your management? There are a fair amount of people that we see in urgent care that it will. The people who are the COPDers or the immunosuppressed or those people that not only necessarily would you have to think about you're going to treat them with the Paxlovid or the Tamiflu, but also what is their risk of decompensation? Is this somebody that we really have to worry about down the road? Maybe warn them that your likelihood of getting sicker is more possible than it would be for someone who didn't have all those comorbidities. Sometimes people talk about using the multiplex panel testing for antibiotic stewardship purposes. Look, you're positive for rhinovirus. You don't need that antibiotic. I think in some cases that's good. And in the future, we'll probably see a little bit more of that. But by and large, because of the expense and it's something they're going to be sending out, it's not really that useful right now, but I think moving up in the future, we might see a little bit more of that. I know in a lot of other countries, they are routinely testing people for antibiotic stewardship purposes to say, hey, look, you don't have anything bad. This is X, Y, and Z virus that doesn't need anything. So stay tuned on that, but not something that you should really be routinely testing everybody with the respiratory virus panels. Joe, you want to comment on that at all?
Yeah, I agree. It's been shown to be helpful. It's been shown that if you have a positive viral diagnosis, that the clinician is less likely to prescribe antibiotics. But I think that's a generalization. And if you yourself as a clinician feel comfortable not prescribing antibiotics and having a discussion with the patient that, hey, look, even though your flu and COVID tests are negative, this is most likely a virus. You don't have pneumonia, you don't have congestive heart failure, you don't have COPD, you don't have an asthma flare. And so you just have to write it out. It takes longer to do that. And that's maybe part of the equation. You have that positive test and you don't have to have that long discussion. You can say, hey, you got rhinovirus or you got the old coronavirus. And it makes it simpler. Like we said, definitely decreases antibiotics. Is it better? Is it less expensive? And maybe the jury is still out on that. I think in urgent care, where you have people coming to work from a lot of different backgrounds and different experiences, it probably does make it easier to have that positive viral diagnosis.
I remember the days when COVID was a little more prevalent and you'd think to yourself, oh, this person's going to ask me for an antibiotic for their cold. And then that test pops positive and you're like, yes, I don't have to give them an antibiotic. I can give them a good reason. A little less common now because COVID is a little less common. But isn't that horrible that we wish these horrible diseases on people just to make our lives a little bit easier? Just like the old positive strep. Yes, the strep's positive. I can just write that amoxicillin. All right, so let's talk about cough. So the cough of acute bronchitis is going to last a long time. I always tell people it's going to be at least 3 weeks and it's going to linger. It's going to taper off. This is not like your average cold where it just turns off in a week to 10 days. But people can even cough longer. So you didn't really talk about it too much in the article, but do you have a take on the post-inflammatory cough syndrome, as it were?
Yeah, I think with post-infectious cough, it can last up to about 8 weeks. Once you hit the 8-week period or so, then you start thinking more that this could be a chronic cough and trying to think of other possible etiologies, whether it's like an upper airway cough syndrome, asthma, GERD, or some kind of laryngopharyngeal reflux. And while those things are hard to explore fully in the emergency department or in urgent care, there are some things that we can do on an acute basis to kind of start the ball moving. You can talk about things that might trigger the cough, do another exam, do another full history, get a chest x-ray or some kind of other imaging if it's warranted. Then I like to think of it as more of an outpatient workup, like whether their PCP sees them and sends them for spirometry, or if their PCP decides to send them to a pulmonologist. Past 8 weeks, you're trying to think this could be more of a chronic cough and have a different cause.
I always try to at least reassure people if it's slowly improving, it's probably not something you're really going to have to worry about. I always frame it as this is just really annoying, but not anything serious or life-threatening, assuming you've ruled out all the bad stuff like we were talking about earlier. They want to sleep. Their partners want to sleep. They're so sick and tired of the coughing. They want it gone. But sometimes just reassuring them that it will go away all by itself usually is sufficient in that case.
If there were a really effective antitussive agent, I think the whole deal with cough would be a lot easier.
Yeah, right.
But that's part of the problem. So, Evan, there's a nice box section in the article that talks about antibiotics stewardship. Can you summarize the tips you presented on talking to patients and how to talk them out of antibiotics for bronchitis when they may have been used to getting them over and over again in the past?
Sure. I like to focus heavily on educating patients. I think it's important to first assess what level of medical literacy they're at and meet them there. I like to do a little bit of a basic discussion about pathophysiology. And with respect to acute bronchitis, I try to say more than 90% of these cases are caused by a virus. And for viruses, we do not treat them with antibiotics. Antibiotics are used for bacteria, and this is not going to really impact your virus. Really, in fact, if I do give you an antibiotic, there's chances for bad side effects that I don't want to have happen for you. And it could make it harder to treat infections in the future due to the resistance of the bacteria. And I let them know that we're always here to see you again. You can come see us anytime if things get worse, and we can discuss if you need antibiotics in the future. And I try to give them a little quick speech about the supportive things they can do at home, the more benign home remedy things to give them something to try and have them leave knowing that there is something they can do to help their symptoms.
I also like to make sure that they feel supported in that if something goes wrong, we are here to help you, what to do if things get worse, other things that you can try, or if it persists longer than you expect. I find not throwing them out of there like, you have bronchitis, there's nothing we can do, you'll be sick for 2 weeks, have a nice day. Letting them know that I understand that this is miserable and I want you to come back. I want you to call. I want you to go see your PCP if things get worse. That way they feel like you're not just leaving them to hang out in the breeze with their cough.
And that could be hard too, because you see so many patients in a day and it's the same speech over and over. But I really do think it's pretty important.
I actually sometimes apologize to people. I'm like, I know this sounds like this is a speech that I'm giving you because it's rote memory at this point. I say the same thing to everybody, but it's funny.
I'll sometimes tell patients too, because like you said, if you look back through the chart and they've gotten antibiotics, a Z-Pak every time, even like a year ago, I'll say, hey, look, this is relatively new knowledge that you're not going to get any better because of this and that there's harms from it. And admit that it's new and different.
Yeah.
And sometimes patients will accept it a little bit more versus me not knowing what the last person knew, that now we are possessing better knowledge.
All right, let's talk about cough and cold medicine, the elephant in the room. Guess what? It doesn't work. But we're hearing a lot about some badness associated with particularly antihistamines. I know a lot of clinicians that will tell them to go take loratadine for their cough and cold symptoms, or maybe take a Benadryl at night before you go to bed. And a lot of the multi-symptom cold medicines have antihistamines in them. Even a very popular prescription one that people have been prescribing a lot for kids with the brompheniramine in it. Is there any role for any of this stuff, or should we just abandon it altogether? Is there really anything we can do for cough that's evidence-based that's going to work more than nothing?
With antihistamines, especially diphenhydramine Benadryl, it's a first-generation antihistamine. It actually doesn't really do a whole lot for bronchitis and actually can worsen it because it can dry out the nasal passages. In addition, it does have a pretty decent side effect profile, especially for some older patients. You think about the anticholinergic toxidrome, the sedation, the altered mental status, the changes in urinary output. These are all things that can hit our older population of patients especially hard, and they're using it without much benefit for their bronchitis symptoms. The second-gen antihistamines do have a better side effect profile, but still haven't been shown to improve symptoms at all. Instead, I think the benign things like cough drops, honey, humidifiers, hydration, rest, nasal saline irrigation, anything that's benign and could potentially help isn't a bad thing for these patients.
Yeah, when I'm teaching, someone will try to give an antihistamine for a cold or a bronchitis, and I'll say, what type of medication is that? It's an allergy medication. Okay, well, do you think the patient has allergies? No. Then why are you prescribing it? It's allergy medicine. It's not really going to help the patient at all. When people are coughing up stuff, I'm like, good, you're getting it out of there. You don't want to dry it up. You want to cough it up. So yeah, lots of different ways to approach that. But I think instead of throwing more medications at people to try and help their symptoms, we're starting to realize that this is a bunch of chemicals that's really not doing a whole lot. And maybe we should back off a little bit and really do more symptomatic stuff. Can we talk about benzonatate?
Yeah, back to that magic cough medicine if we had one. This one doesn't work very well either. I don't personally prescribe it for patients. I don't think it really works a whole lot. It's not very proven.
Yeah.
Really not a lot of evidence that it works. Every once in a great while, I will get somebody that'll say, can I have those little yellow pearls? They work great for me. And I'm thinking to myself, yeah, all right. Maybe for you, but probably not for most of the population. And those people I'll give them to. A lot of times I'll say to people, have you had anything that's helped you before in the past? And if they say X, Y, and Z, maybe I'll consider prescribing it. What about narcotics?
I can't think of a real role for narcotics. Too significant of a side effect without much benefit.
Yeah, I usually tell people, because they all say that it's helped them. I say it's helped you sleep through your cough. That's all that it really did. It didn't really make your cough better. You just weren't cognizant of it at the time. And then, of course, highlight the sedative and the addictive potentials of it. Around here, you can't even buy it. If I wrote a prescription for it, you wouldn't be able to find a pharmacy that would fill it because they just don't even stock it anymore.
So bronchitis is an itis, right? Which means inflammation. Why do we need to avoid corticosteroids? It seems like they should work for the itis, right?
You would think, you certainly would think. There was a large randomized control study of over 400 patients. These are people with acute bronchitis. Control had no medications. The experimental group got a basic regular course of prednisone. It was 40 milligrams for 5 days. The prednisone did not change the duration or symptom severity at all. And these steroids are not benign medications. I think this is the common theme here. Has a pretty significant side effect profile, especially for certain populations. It increases your blood sugar, which is particularly important for our diabetics. It worsens swelling, so for your heart failure patients, that's important. It can change your mood, change your sleep. Those are all things you can't neglect. You can't do it.
Maybe they should change the name to bronchosis.
Yeah.
Yeah, that would be good. Then it wouldn't be an itis, right? I had a lady a couple months ago who came in with, I have bronchitis again. I said, tell me about that. She says, I get it every month. Oh, yeah, I get it every month. I get cold symptoms. They tell me I have bronchitis. They give me steroid dose pack. Okay. So I go back in the computer and I look, and literally every 3 to 4 weeks for the last year, she's been diagnosed with bronchitis. She had cold-like symptoms and someone gave her a steroid pack. And it dawned on me. She's like, why do I keep getting sick? And I'm thinking, guess what? You're immunosuppressed from all those steroids you didn't need. You don't have bronchitis. You have a cold. And I'm not giving you steroids. And I was waiting for the war. I was just waiting for that war. And she says to me, oh, thank God, I hate taking those things. I just was so dumbfounded by that now I ask. When people think they need the steroids, I will say to them, do you like taking them? Do they make you feel any better? And I would find a fair amount of people say, no, I hate taking them, but they've been so conditioned to think that they need them. That's what they're expecting. And as soon as I explain to them the side effects and that they don't really need it to get better, they're very happy to not take the steroids. Definitely something worth having a conversation instead of knee-jerking those steroids because they've had it before. So you've got at least 3 kinds of stewardship in here. Oh, we're all about the stewardship here at the urgent care group. So we're talking about antibiotic stewardship with bronchitis. We're talking about steroid stewardship with bronchitis, and even radiologic stewardship. Don't do too many x-rays. And for that last one, why do you think that clinicians really order so many x-rays for what they think is bronchitis or for cough or that sort of thing? And how many of them end up being positive? Like very few. So it obviously costs money. And there's that radiation we got to worry about. Granted, chest x-rays aren't as much as, say, LS spines, but it's still pretty significant, especially if they're going to get one every time they get a cold. So how are we going to know who needs a chest x-ray, who doesn't need a chest x-ray, and how to limit that in an evidence-based sort of way?
First, to kind of speak about why we order so many chest x-rays, I think we as clinicians like to do things for our patients. A chest x-ray is pretty easy, pretty quick, and relatively cheap, cheaper than other things that we order. It feels like we're doing something to evaluate our patients. Also, there's this whole culture of defensive medicine, especially in emergency medicine and urgent care. You're always trying to cover all of your bases and make sure you're leaving no stone unturned. So whether that's for better or for worse, I think that might be part of the reason why people are ordering so many chest x-ray. I think really the only times you need to order a chest x-ray is if you really think this patient could have pneumonia and you want to find it possibly on the chest x-ray. I think we mentioned it at least a couple times in the article about things that would tip us off for pneumonia: fevers, tachypnea, tachycardia, profound fatigue, focal lung findings on lung auscultation, decreased O2 sat. Any of those instances, I think a chest x-ray would be warranted. Otherwise, I think it's more of just feeling like we need to do something and making sure we cover all of our bases.
I'd probably add immunosuppressed or people with chronic lung disease to that list too. Maybe not necessarily on everyone, but have a little lower threshold for ordering an x-ray for those patients. But by and large, most patients with bronchitis, they don't really need that chest x-ray. But you're right, people don't want to leave any stone unturned. They're practicing defensive medicine. They're concerned about things. That's a really good rule of thumb. If they have normal vitals and not significant lung findings, then even if they did have pneumonia or a small amount of pneumonia, you're probably not going to be missing too much by letting that go on the chest x-ray. Joe, your thoughts?
Yeah. Yeah, no, I agree. I think chest x-rays, sometimes you're looking for something that maybe there's a good chance that it's there and you want to get a yes, no answer. But I think in a lot of people's minds, it objectifies a benign diagnosis. You think, I did my history and my exam. Why don't I just get a chest x-ray and have it be cleared to objectify things? But I agree. A lot of those risk factors that you talked about for pneumonia are also dyspnea, low sat, abnormal lung exam are going to be your CHF indicators and some of those other things that can masquerade as bronchitis, which are also going to help to get a look at the lungs with a chest x-ray too a lot of times. So applying that consistently, regardless of what you think's going on, is a good idea, and make your chest x-ray higher yield.
I do find some people are ordering the x-rays as an excuse to not prescribe antibiotics. Congratulations, there's no pneumonia on your chest x-ray. You don't need antibiotics. But I think that's a slippery slope. Are we going to start x-raying everybody with a cough just so we can say they don't need antibiotics? Definitely a balance in there.
Only if their viral test is negative.
Right. Yeah. Slippery slope, case by case basis, all those buzzwords that we say. Have a threshold, but don't go overboard either.
Hey, sputum culture and characteristics. These are things that a lot of patients and even clinicians seem to focus on. Is it helpful at all? Yellow, green, brown, clear? Does it matter?
I wish it mattered, but not really. Yeah, it doesn't predict bacterial versus viral. You can't really use it for guiding your management, unfortunately.
Yeah, unfortunately.
How do you get around that when patients are like, but my sputum is green? What do you say to them?
I like to talk about why their sputum is different colors. I explain that there's inflammation going on in your lungs. These are the cells of your respiratory tract coming back up. You're coughing them up. They can be a variety of different colors, and it really doesn't mean a whole lot about what pathogen is causing your condition.
Yeah, I usually say one of two things, either dead viral infested cells that you have to cough out. So that's great that you're coughing up sputum. Or the other option is it's just inflammation. It's your body's immune system doing its job. So that's actually a sign that you're getting better. And some people will buy that. Some people won't. But yeah, that's usually my general go-to script. Oh, yes, the fourth stewardship. You know what? Let's just talk about albuterol.
Yeah, albuterol. I think for someone with bronchitis, the obvious, straightforward answer is that the one set of the population that you're going to use it for are your people that already have diagnosed lung conditions, your asthma patients, your COPD patients. For the vast majority of the time, they're already going to have prescriptions for albuterol to be used. I think if they're in an acute exacerbation, you can change the frequency at which they use the albuterol to get through their acute illness, and then they can go back to their normal regimen. For the people that don't have a pre-existing lung condition, it's a little more tricky to decide who needs the albuterol and who doesn't. The way I think about it is anybody that I think is having signs of bronchospasm or wheeze, it wouldn't be the worst idea to give it a try. But if you have somebody with clear lungs, looks well, usually a younger patient, I don't think you really need to try albuterol on those people, and it really won't give them much benefit. But the wheezers, the bronchospasmers, probably could use a little albuterol.
Most of the studies show that it really doesn't do a whole lot, but I have a really hard time not writing albuterol for somebody that's complaining of chest tightness and is actually wheezing on exam, especially with that little prolonged expiratory phase going on there. Yeah, I call it reactive airway disease or whatever you want, but I guess I overprescribe the albuterol a little bit, but not for anybody that doesn't have any abnormal lung sounds or any shortness of breath or that sort of thing. Joe, what do you do?
I think you hit the nail on the head. The one group that's maybe a little bit less obvious than them is the person who can't complete a sentence without coughing, or you say, hey, listen, take a deep breath so I can listen to your lungs, and they're coughing once they take anything greater than a tidal breath. What I'll sometimes do for that group where maybe they wheeze with that cough, with taking the deep breath, and it's a little bit more convincing. Sometimes I'll try some albuterol and see if they feel better. Do a little albuterol trial in the clinic or in the ED. And if they feel better, then you'll know, okay, it's worth an MDI prescription for them if they've never had it before.
I think there are a fair amount of people walking around out there that do have some subclinical asthma that have never been really tested, or people that were previous smokers that may have a little bit of a subclinical COPD. Maybe those are the people that do a little bit better with the albuterol. But that's a great idea to give them a trial in the clinic and see if it helps.
Yeah, they're taking that deep breath more easily, talking a sentence and not coughing. And it helps them know that it's going to help to now all of a sudden learn how to use an inhaler that they never had to before.
Dr. Olympia and I, when we work together in the pediatric emergency department, we do the same thing. We let the kids trial the Albuterol a little bit, gives them a little more peace of mind as their parents too. It's a pretty cool technique.
I mean, one of the other things, I don't know if you've heard the podcast before, but we like to talk about our special populations, especially as Tracy and I approach Medicare age. And the extremes of age are the special populations. But what are some of the special populations where we have to take extra care of our evaluation and decision-making when it comes to acute bronchitis? I think we talked about a couple of them already, but if you could summarize, that'd be cool.
Yeah, I think we touched on the immunocompromised folks already, but it's the same general management. You're just a little more aggressive with the testing, the imaging, and the antibiotics. These are people that are predisposed to infections of all types. So if you suspect something, it might not be a bad idea to treat or test for it. The other one that we talked about a little bit as well is the older and elderly folks. Same management, but it's especially important to avoid the Benadryl for the anticholinergic toxicity, the sedation, trouble with urinating, orthostatic hypotension, and also the decongestants too. Those can be tricky. They can cause hypertension, anxiety, troubles with sleep, headache. And finally, the pregnant patients. I think we talked about narcotics earlier, the codeine, especially for pregnant patients. You don't want to have any chance for neonatal abstinence syndrome, neonatal respiratory suppression, depression, or a prolonged labor course. So those are the three that we got into in our article.
Let's wrap it up. So some take-home points. What sort of highlights would you hit on the patient education?
I think meeting the patient where they're at from a medical literacy standpoint, explaining their pathophysiology in very simple terms, and describing why we're doing what we're doing.
Yeah, definitely. I think reassuring that this is nothing serious, it will go away. Also extremely important why you're not giving those antibiotics, why those steroids aren't necessary, just to not only treat them appropriately, but we're always concerned about those Google reviews. A well-educated patient is less likely to say, they didn't give me that antibiotic, I'm going to write a 1-star review for them. And it doesn't take that much time. Taking 30 seconds to explain something to someone and maybe placating them a little bit when you didn't meet whatever expectations they had when they walked in the door for what their treatment would be goes a long way.
Yeah, I agree 100%. It'll make the next visit a little bit easier too, because they heard that talk. Chris Chow talks about the spiral of, gosh, I forgot what he talked about, but the doctor has a bad habit. The patient believes that it's the right thing to do. And the next time they come back, you're kind of locked into that. So you have to unravel that spiral to change their expectations. And really the only way to do it is with communication.
And that's one of the dangers of urgent care, because they're going from place to place, seeing multiple different providers with different habits, for better or for worse. If they went someplace that likes to give a lot of Z-Paks to people, then that's now what their expectation is. You need to make sure that you always see what their expectations are so that you can provide the proper education so that you have a satisfied patient.
Evan, it's been great to have you. Thank you. It was a great article. I think you guys covered everything we needed to know and threw some evidence in there to just solidify it. And we really appreciate it. Thank you for your time tonight. It was been fun to talk to you.
Thank you. Thank you for the opportunity. It was a lot of fun.
Cool. Do we know what we have next month, Tracy?
I think we're going back to asthma. We did an asthma probably just a little over a year ago, but it was before the new guidelines changed regarding inhaled corticosteroids acutely for sudden symptoms. Dr. Chow, we'll talk about Chris again, rewrote that aspect of the article, and we're going to re-release it and republish it. Bye-bye, everybody. I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to evmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's evmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.